Hello, I'm Dr. Daniel Griffin.
And I'm Dixon DePommier.
And today we will be discussing sexually transmitted infections.
Wait a minute. I thought it was sexually transmitted diseases.
Well, today we're going to be doing sexually transmitted infections of males. And why? I think your question is, why infection versus disease?
Well, I know the difference between infection and disease, but
What is the difference?
Well, all infectious diseases start out as infections.
Okay.
But not all infections result in disease.
Interesting.
So,
and that's the point. That's the point.
You mean I could have determined this for myself without asking the expert?
So many individuals
Yes.
can be asymptomatically infected.
Indeed.
And actively transmitting these organisms,
Right.
but they themselves have no disease, no manifestations.
Sort of like typhoid Mary, for instance.
And that's the point which we realize. Is it used to be we would wait for a person to come in reporting that they had a disease, reporting symptoms. We now realize you have to be a bit more proactive. And this is a major problem.
That's interesting.
Every day, I'm going to make you guess. How many people do you think acquire a sexually transmitted infection per day?
Of the entire world's
You got 7 billion people.
7.6 billion, excuse me.
7.6. It keeps going up. It's like my children's ages.
Despite all these infections, they keep going up.
Which should be, I guess, encouraging.
How many people out of those 7.6 billion every day get a sexually transmitted infection?
Per day.
No, I don't even.
Over 1 million.
Really?
Per day.
Wow.
Yes.
So what percentage is that of the 7.6 billion?
Do I have to do that in my head?
Yes.
I was going to do how many million per year, and I was going to say 365 million, which actually is, if you think about it, is up there in the range of dengue.
Yeah. That's a lot.
Which is really a lot. So this is a huge issue.
Wow.
And it includes a number of different pathogens.
Sure.
Syphilis, gonorrhea, chlamydia, herpes, HIV.
That's right.
So there's a number of
Trichomonas.
pathogens. Is that a sexually transmitted infection?
It is in my book, and it is in yours too, because you're one of the authors.
It certainly is. It certainly is.
And it's one of the most common also.
Yes.
But you're right, it doesn't result in a disease all the time. In fact, most of the time in males, it doesn't.
And we're gonna, I don't know if we talk about that in this section, but yeah, we're beginning to realize in both men and women, a lot of times they can be asymptomatic.
Correct.
And then they can be engaged in sexual activities.
Exactly.
And they can be sharing, which we all learned, that's what I learned in kindergarten.
Right.
Maybe people kept doing that when they grew
we
up.
We left one out, and that actually is a sexually transmitted infestation. It's the pubic louse.
Okay. I'm sure we left more than one out, but we'll make sure we cover them all as we go.
Sure.
But one of the things to think about here is that patients will present sometimes with symptoms. Sometimes they'll come and say, I've got an ulcer.
Right.
Painful or non-painful.
Right.
They might present saying they have discharge, I've got some drainage.
Sure.
They may come and say, I had a high-risk encounter, and I'm a bit worried that I may have picked something up.
Exactly.
And maybe they know that they may not need to have symptoms.
Interesting.
One of the things that we've also introduced because of the clinical disease, because there isn't always symptoms, is screening of at-risk populations.
Okay.
And what puts you at risk for a sexually transmitted infection?
Well, you have to be beyond puberty, as far as I remember.
Not necessarily, unfortunately.
Not necessarily, but
Yeah.
I said usually.
Usually, yeah.
And, sexually active, let's be honest.
So it's a sexual activity. Yeah, that's what puts people at risk. So it's a huge portion
of course.
of our population.
Absolutely.
As far as the diagnosis of these, we're going to sort of run through, I think, a few at a time, specific ones that we might think about and how we'll approach it.
Right.
So one of the presentations might be urethral discharge.
Yes.
Okay, so the urethra, right, is going to be so we're doing male right now. So this is going to basically be the tube that's through the penis.
Yep.
And you may have discharge from the urethra or coming out of the end of the penis. Now, you may just treat it as a clinical syndrome. In a lot of parts of the world, we approach these with syndromatic treatment. We don't necessarily do a swab. We don't necessarily have nucleic acid amplification testing. We may not have access to cultures. We may not even be able to gram stain looking for the classic organisms. And in that case, what we'll do is we'll say urethral discharge falls into a category. We're worried about gonorrhea, chlamydia, and trichomonas.
Yes.
Can't forget trichomonas. And we actually recommend intramuscular ceftriaxone and azithromycin and, in certain circumstances, metronidazole. So you look at that, they come in with discharge and they're getting potentially 3 drugs. It's a lower dose. It's a ceftriaxone 250 milligrams, intramuscular times 1. We'll often give them a gram of azithromycin right there under observation. We may, instead of metronidazole, use tinidazole, where you give a 2-gram single dose. And the idea here is you're making sure you treat the person.
Right.
There's also something called expedited partner treatment,
Aha.
where you'll say, is your partner here with you?
Right.
Why don't we treat them as well?
Sure.
Because if they're sexually active and one partner has the urethral discharge, they've probably infected their partner.
Right.
And you may want to also ask the individual, before you invite in their partner, to maybe make a commitment and working with public health to alert other potential partners. Because
Exactly.
people who get sexually transmitted infections may have more than one partner. So you want to make
It
sure
doesn't
you take that.
arise spontaneously. Let's put it that
That's
way.
true. This came from somewhere.
Came from somebody.
Another way they might present is with a scrotal swelling.
Wow.
You might have an acute area where the scrotum is swollen, maybe superior to the testicle. The epididymis might be tender and inflamed. And again, you're going to be worrying about gonorrhea and chlamydia in the young and E. coli in the older male.
Interesting.
And so you're going to approach this the same way as your urethral discharge. You're going to be giving them the intramuscular ceftriaxone and the azithromycin.
Right.
Trichomonas is usually not an issue in this context. Usually not.
Although it can create prostatitis in some individuals.
Yeah. So I think
I've
that's
read.
important. No, I think that's true. I think that's important. Now we're going to get into genital ulcers.
Right.
And we're going to break these down into painful and painless.
Right.
Painful genital ulcers, this is another one of those pearls. Painful genital ulcers are almost always herpes.
Got it.
And it used to be, when I was growing up, that herpes type 1 infected the mouth and herpes type 2
Yeah, exactly.
infected the area down
That's
below.
not true.
Nowadays, it's all mixed up. I have no idea how that happened, but we're looking into it. What if the ulcer is painless? Then we have a list of potential etiologies. Syphilis, and for those of you watching, you'll be seeing a chart now. You can actually see all the different.
Often called a chancre, by the way.
A chancre, yes. Syphilis, right now, we have so much syphilis in the United States that in my clinic, we have trouble keeping up with medications for it.
And there's a lot of resistance?
You know,
Or not?
syphilis, fortunately, no.
But gonorrhea, yes.
Gonorrhea, yes. We worry gonorrhea may become the first organism resistant to every known antibiotic, so that's a use. But fortunately, here we are in this day and age. Syphilis is still universally sensitive to penicillin.
Interesting.
So in acute syphilis, we can do a 1 shot of benzathine, injectable penicillin, 2.4 million units. And that's the treatment all across, particularly in pregnant women. In non-pregnant adults, we have other choices. If it's late syphilis, we're actually going to do a series of 3 injections, or if it's gummatous syphilis. This is where they have syphilis, but you're actually seeing heaped up mounded tissue. And so some acute infection can be significant enough that it requires a 3 treatment
So
approach.
neurosyphilis?
Neurosyphilis, we still recommend 2 weeks of IV penicillin. But again, penicillins.
So,
Other ulcers, other things that can cause ulcers, we could have chancroid. These tend to be, interesting enough, quite painful. And so there's sort of a mnemonic for remembering, you know, with chancroid, it's Haemophilus ducreae, and they may cry, they do cry. So that's a bit of a mnemonic. granuloma inguinale, where they might have tender lymph nodes associated with it. And this you're going to actually treat not just for a period of time, but you're going to treat until all the lesions heal.
Got it.
So this could be a little longer treatment. LGV, lymphogranuloma venereum. And this, there are no clinical trials. We're not sure how to treat this, so there's expert recommendations on what to do. And HSV, as we talked about, herpes simplex virus.
Right.
These are going to tend to be painful.
Yes.
Usually the initial episode is more severe and extensive, and then recurrences will tend to be less severe. So these
are
to
keep track of.
Yeah, I mean, and this is a huge burden throughout the world. And it could be very difficult as a clinician, sort of putting yourself into different cultural contexts where these have different levels of prevalence, and there might be different social ideas on how these are approached.
That's right. That's right. And you may even have cultural differences as to how they're transmitted. So convincing some cultures, particularly, I remember the incident in South Africa where the president of South Africa actually proclaimed that HIV was not a sexually transmitted infection. I will use the word infection right now.
Yeah.
And of course he was wrong, but it influenced a lot of people in their thinking.
Yeah. Well, I like that you bring up HIV, because in our male sexually transmitted infections, this will also be true for female sexually transmitted infections. HIV worldwide is a huge problem.
Yes.
There's over 35 million people infected worldwide with HIV.
Still.
There's over 1 million new cases every year.
Wow.
Despite effective therapy, this number continues to grow. And the acute presentation of HIV might present as a rash, might present with swollen lymph nodes, might present with fever and a headache.
And it elicits all the other diseases that respond to immunosuppression, because HIV immunosuppresses. So all the other diseases that used to be infections now become diseases.
Yep.
And that's, people make their livelihood just trying to get rid of those other infections rather than the HIV itself. So it's been a long, long struggle since the early 80s when this was first realized. And we're still behind the 8 ball, so to speak, you'd say.
And HIV is very tough to diagnose, I think. I have seen plenty of times when someone had acute HIV infection and it was missed.
Really?
Because it presents so say non-specifically. We don't have a nice ulcer. We don't have urethral discharge. We have fever. We have a rash. We have lymph node swelling.
That's right.
And people often say, "Oh, it's just a viral syndrome." And I say, well, I'm not sure I would use the word just. It is a viral syndrome, and it presents as a viral syndrome.
Sure.
And if we diagnose and start treatment right away, we've shown that this can make a really positive impact on the disease.
Absolutely.
Not only does it improve the acute symptoms, but it may also prevent the virus from filling the reservoirs and may help with overall long-term prognosis.
Great.
So, all right, so we've got a number of sexually transmitted infections to think about, but think about HIV as well.
Indeed.
All right, thank you for joining us.
Yeah, we'll see you again.